Welcome everybody to the next edition of the ATS Pulmonary Rehab Assemblies Journal Club. My name's Lindsay Houchin-Woloff. I'm the Assembly Web Director and I'm a research physiotherapist from Leicester Hospitals in the UK. So before I introduce today's article and panel, I'd like to ask you all to mute your microphones as this session is recorded. When we reach the discussion section, we'd like to have a lively discussion. So you can either ask your questions in person, that would be our preferred option, or you can also use the chat function and we will read out your question. The article we're discussing today is entitled Telerehabilitation Compared with Center-based Pulmonary Rehabilitation for People with Chronic Respiratory Disease. This is an economic analysis of a randomized controlled trial by Angela Burge and colleagues from Immunology Alfred Hospital, Monash University in Australia. Dr. Burge is joining us today. And it was first published online in the Annals of the ATS in September of 2024. Cátia Paixão from the University of Aveiro, Portugal, will present the article today. And we have two experts in our field who will serve as our discussion panel members. They are Chris Mosher, Assistant Professor of Medicine at Duke University School of Medicine in the USA, and Peter Lindenauer, Professor of Healthcare Delivery and Population Science at UMass Chan Medical School, Baystate, USA. We also have Paola Uroz-Guerrero from the University of Newcastle in Australia, who's also a member of our web committee and will help to moderate the discussion today. So with all the introductions over, I'll hand over now to Cátia to present the study. Thank you.
Sorry. Hi everyone, thank you for the kind introduction and thank you to the ATS to be here today presenting this fascinating paper. I'd like to start by saying that I have no conflicts of interest to declare. I would like also to give you a little background to understand better the rationale for this paper. So as all we know, pulmonary rehabilitation plays a pivotal role in the management of chronic respiratory disease with several benefits such as improvements in exercise capacity and decrease in hospital admissions. However, despite these benefits, PR is still underused and challenges are related with program access, uptake and completion. And these challenges can be at participant level, such as burden of travel to center-based programs, but also at system level, such as limited availability of center-based programs. Novel pulmonary rehabilitation programs and models have been developed, and we all know that telerehabilitation has attracted more interest recently. In the recent years with the new guideline or clinical practice guideline of ITS recommending that we should offer the options to patients to choose between telerehabilitation or center-based PR. However, there has been limited work to date to determine the economic impact of new models of PR. The authors of this paper have published recently a randomized controlled equivalence trial that have shown that telerehabilitation is safe and with similar completion rates to center-based PR. Participants also achieved clinically meaningful improvements, providing supportive evidence as a suitable alternative program model. However, an economic evaluation is a critical component of recommendation of a new mode of program delivery. Therefore, the aim of this study, or the main aim of this study, was to assess the incremental impact of a new telerehabilitation model compared with center-based PR using cost effectiveness and cost utility analysis. And the secondary aim was to determine the impact of program completion on healthcare-related costs over the 12 months after PR. This economic evaluation was nested in a randomized controlled assessor-blinded equivalence trial conducted in Australia. It was registered in Australian and New Zealand clinical trials, obtained ethical and governance approval. The authors also published the protocol for the randomized controlled trial and the results, as I have shown you previously, the results of the randomized control equivalence trial. Regarding the eligibility criteria, the participants were included if they had the primary diagnosis of chronic lung disease, if they were aged over 40 years and able to read and speak English. Participants were excluded if they had a primary diagnosis of pulmonary hypertension or lung cancer, if they did PR in the last 18 months, if they present oxygen saturation that impede or lead to a cessation in exercise testing, if they present unstable or brittle asthma with hospital admission or emergency department presentation in the last 3 months, if they had comorbidities that preclude exercise training and were unable to follow verbal instructions, suffer from cognitive impairment, or present a language difficulty. 142 participants with chronic respiratory diseases were recruited after referral to pulmonary rehabilitation and randomly assigned to center-based PR or telerehabilitation in a ratio 1:1. All participants of both groups received the core PR components of exercise training plus self-management education over 8 weeks. Participants allocated to center-based PR received a twice-a-week outpatient group-based supervised PR at their site of recruitment, and participants allocated to telerehabilitation were equipped with all equipment necessary, including bicycle, a 4G tablet, enabled tablet, and also pulse oximeter. Regarding the exercise training sessions, the first one was supervised by a physiotherapist during an initial home visit, and the remaining 15 were conducted twice a week in virtual groups using video conferencing and synchronous supervision. The program completion was defined as a minimum of 70% attendance of scheduled sessions. Regarding the outcome measures, all participants undertook an assessment at that was center-based, and the measures were collected at baseline, end of PR, and 12-month follow-up. Included measures of health-related quality of life that were the Chronic Respiratory Disease questionnaire and also the 36-item short-form health survey. Both measures were used for effectiveness and utility. The effectiveness was defined as the change in the CRQ dyspnea domain score from baseline to the end of PR, and the short-form health survey scores were used to derive utility scores for health status. The cost utility analysis used quality-adjusted life years converted from utility scores using the area under the curve approach. Regarding the research use, all costs were calculated at the time of expenditure. The total costs were adjusted for inflation, and regarding the data for research use and unit costs for intervention were collected prospectively and then calculated per participant. Direct healthcare costs included staffing and equipment provision. The direct non-medical included participants' expenses, namely the transport to center-based PR sessions, and indirect costs included monetary value attributed to time lost from work or leisure activities. Regarding the costs for the 12-month follow-up, costs for each participant were sourced for medical care and investigations and prescribed medications funded by the federal government, as well as the emergency department presentations, hospital inpatient admissions, and outpatient appointments funded by the state government. Regarding the healthcare personal out-of-pocket expenses, they were obtained directly from participants via monthly telephone calls to document healthcare contacts outside of hospital or medical provider databases, including community health services. The participants used an intention to treat analysis. The total costs were weighted by time, and the value of 0 was inputted for 12-month follow-up SF60 scores to compute QALYs. Missing data were addressed using multiple imputation for change in CRQ-2 and SF6D. Descriptive statistics were reported according to data type and distribution. The general linear models were controlled for baseline values and were used to access group values and differences between groups for the change in CRQ-DU and QoLIs. Generalized linear models were used to access group values and between group differences for costs. The results of cost effectiveness were expressed as bootstrapped point estimates. The estimates were then plotted on a cost effectiveness plane, here in your right of your screen, and I will try to explain briefly these planes. So in x-axis, you can see the effectiveness going from the zero, or the center, to the right means that treatment is more effective, and to the left, the treatment is less effective. In high axis, you can see the costs. So going from the zero to upward, you can see the treatment is more costly, and downward, the treatment is less costly. This can split this plane into 4 quadrants. The northeast, that means the new treatment is more effective but also more costly. Going to the southeast means that the treatment is more effective and less costly, so the new treatment dominates. Southwest, you can see the new treatment is less costly but also less effective, and the northwest plane means that the old treatment dominates because the new treatment is more costly and less effective. As this was an equivalence trial, the equivalence margins for clinical effectiveness and utility were applied to the cost effectiveness plane using the minimal clinical important differences. In the absence of a defined equivalence cost margin, a range of thresholds were used, and equivalence of cost effectiveness was demonstrated when 95% of the estimates fall in the area within the equivalence margins. In addition to the cost effectiveness and cost utility analysis, from a societal perspective, a pair protocol analysis with participants who completed PR and a subgroup analysis with participants with COPD were undertaken. A sensitivity analysis using health sector costs to determine the cost effectiveness was also performed, and a multiple linear regression was used to quantify the magnitude of the effect of baseline clinical features and program completion on total healthcare costs in the 12-month follow-up. The internal rate of return was calculated over a 5-year time horizon, informed by trial parameters and that incorporation, and this means the ratio allocation for participants to telerehabilitation and center-based PR, the cost of program provision for both interventions, the observed program completion rates for both groups, and the total costs over the 12-month follow-up period associated with program completion or non-completion. Now, moving to the results, we can see in our baseline participant characteristics that the groups were well matched at baseline, with majority of their participants being diagnosed with COPD. The proportion of participants who completed PR was similar in both groups, and we can also observe that the cost of program provision for telerehabilitation was greater than the center-based PR, with a higher proportion of costs in the telerehabilitation being associated with health sector. In the center-based, the majority of costs were related with individual participant. There were no significant between group differences in costs over the 12-month follow-up period for effectiveness, cost utility, pair protocol analysis, sensitivity, or subgroup analysis. And now moving again to our cost effectiveness plane, I hope that you understood the different quadrants. So we can see an even distribution in all quadrants of the estimates across the cost effectiveness plane, giving no chance to dominating one intervention, so confirming that the cost effectiveness was similar between interventions. Regarding the margins of the minimal clinical important difference, or the equivalence margins for effectiveness, 97.4% of estimates fell between these equivalence margins, confirming the equivalence of cost effectiveness. A range of values for theta were applied to assess the effect on probability of equivalence in terms of cost effectiveness. There was 95% of probability that telerehabilitation was equivalent to center-based PR when theta was $11,000. The same was observed for cost utility, per protocol, and sensitivity analysis. However, a subgroup analysis with participants with COPD identified a slightly higher value, the $12,000. The completion of pulmonary rehabilitation, regardless of program model, was associated with a significant reduction in total costs in the following 12 months, as well as the female sex. The authors also did a post-hoc analysis based on sex, demonstrating no statistically significant difference in group allocation or program completion, but there were significantly fewer admissions, all-cause and respiratory related, in females during the 12-month follow-up. The internal rate of return over 5 years was 134% using the study parameters. The 50% of participants allocated to each intervention, the completion rates of 81% in center-based and 84% in telerehabilitation group, and a conservative assumption of 3% improvement in overall program completion. If a 5% improvement in program completion was able to be achieved with both group program models available, the internal rate of return was 218%. Now, moving to discussion and a quite conclusion, from this paper I could highlight 3 main messages. The first one is that telerehabilitation, this analysis supported adoption of telerehabilitation as an alternative program model for delivery of pulmonary rehabilitation. No differences between telerehabilitation and center-based PR in terms of costs or benefits over the 12-month follow-up were observed. The second message is this is the first cost-effectiveness comprehensive analysis of pulmonary telerehabilitation with a model of video conferencing and synchronous supervision. No differences were observed in direct costs between telerehab and center-based PR. The authors justified this because the smaller group size and equipment requirements for telerehabilitation. These values contrast with the previous study using a low-cost telephone support model, which demonstrated lower costs in comparison with center-based PR. And this highlights, the third message that I could observe is that this study highlights hidden costs associated with center-based PR. In Australia, there is a system that is no out-of-pocket costs to attend center-based PR. So the actual cost of participants may be prohibitive when travel, transport, time, and care requirements are incorporated. This is a research study, and there are limitations in all the studies that we read. So the authors highlighted limitation, the conservative costing estimates in the context of a randomized controlled trial, such as the device, internal access provided, interventions delivered by trial staff. The costs were specific to the Australian healthcare system, so this could limit when we are observing or trying to apply these in other countries, and further work regarding implementation in clinical practice will further inform the accuracy of these estimates. When I was reading this paper, some questions come across my mind. So I observed that maybe COPD is more expensive, and I would like, if the authors allow me, to ask these questions, why? The female sex seem to be protective. I would like also to further discuss it, and this model is an option. We observed in the discussion another model also conducted in Australia. So which model of telerehabilitation should we use? Thank you very much for your attention, and now I pass back the word to Dr. Lindsay. Thank you so much.
Thank you, Cátia. I think You did a great job of explaining some complex economic analysis, so thank you. And congratulations to Angela and team. It's a fantastic addition to the literature to see the health economic analysis of rehab out there. So thank you both. I'm going to hand over to Chris or Peter to start the discussion. And just whilst the audience are thinking of questions, you can either put those in the chat or raise your hand using the reactions function. But Peter, I don't know, do you want to start?
Cátia, thank you for that review of this really important paper. Obviously, this field is very focused on understanding the relative costs and benefits, both from in terms of health outcomes and economic outcomes of center-based versus telepulmonary rehab. And I found this study to be very interesting personally. And thank you for the presentation. I guess I'd just make a couple of observations and maybe a question or two. So, my first observation is that this study took the societal perspective when approaching understanding, the cost and cost effectiveness of the programs, and which is, a good way to do things. But if I think about how this applies to my own health system here in, Massachusetts, our health system has to sort of make decisions about investing in these programs or not. And as a health system, we don't, typically place or have the ability really to put value on the time of the patients, like the time that they spend coming to receive their care. So that was sort of an observation, and I think it's important to bring up because the main drivers of the costs that I sort of noted while you were showing the slides were, an $800 additional cost for center-based rehab associated with participant time, which makes sense if you're, valuing the time of people traveling to come to receive their care. But again, it sort of depends on whose perspective you're taking as a decision maker. Is it society or is it a health system? And in different parts of the world, decisions are made sort of either at a national level or at a local level. But I think it's important too because I mean there are nuances to doing economic evaluation, and Angela can probably educate us about this. But like assuming a number, a significant fraction of the participants were retirees or not working, and so how you value the time of people who are not working can be, there are different approaches to that. So I was kind of curious about that. And then the last comment I'll make is just that on the flip side, another key driver of the cost was the $1,100 higher health sector costs for the tele-rehab compared to center-based rehab, which I was surprised by. And I'd love to sort of understand that a bit more. I guess what I was thinking is that maybe that doesn't consider, the potential marginal cost of having to build new centers, but just maybe sort of the cost of making do with existing centers, whereas the cost of the tele-rehab was probably all considered a new cost per participant. But at least in the United States, there's not enough center-based pulmonary rehab. So the center-based costs might actually be higher in a sensitivity analysis because you might have to factor in like the marginal cost of building new centers. So anyway, those are a bunch of thoughts, but I really think this is a great paper and a great presentation. So thank you.
Angela, do you want to come back on some of those
comments?
Thanks.
Thanks for the opportunity to talk about our work. So thanks to the organisers and to Cátia. So in terms of the perspective, I think that we particularly were interested in the societal perspective in this case because we are interested in getting people into pulmonary rehab programs, and by not factoring in what it means to the people. And I agree that the healthcare system, care how much it costs the healthcare system, but people coming care about, what the out-of-pocket costs are going to be for them. What we in our previous study, so that in the home-based study, when we did the implementation of that into usual care as part of our centre, I think of those, it was 100 odd patients, 99 of 100 or something like that would never have come to a centre-based program. So that showed us that by offering alternative models, we were in fact finding people that were not within our usual patient cohort for our centre-based programs. And if people are working, that is an additional problem in terms, you're right that most of the people in this study were retired, but I wouldn't say that that's necessarily representative of our cohort any longer. So, I think that those things are important to people, and it's important for us to consider when we're wondering why people aren't coming.
Yeah, I think Cheryl's agreed with you in the chat about, travel and the associated costs seem to be the primary barriers for people not attending centre-based. So they're important factors to consider. Sorry, Angela, were you going to add anything else?
I was just going to touch also on Peter's question about the setup costs, and you're right that we did assume centre-based programs were in existing physical centres, but we were setting up tele-rehab kits from scratch. Part of the reason we changed the from 1 year to 5 years for the rate of return was because we anticipated a 5-year kit life, I guess, but that's actually been a very conservative estimate as it's turned out. Some of those kits are still actually in circulation in usual care. And I think that is, I think Cátia pointed it out in her review, which was that we did take a conservative perspective in the costing of what we provided to people, because we provided everything, including the internet. And in what is usual care now for our centre, that we use people's own resources. So if they have internet access, we're not providing internet. If they have, a treadmill at home, we use their treadmill. We don't take the bike, those sorts of things.
That's great. Chris, I'll let you come in next.
Yeah, thanks, Lindsay. Thank you and organizers for organizing, and as well as Cátia for that excellent presentation. And Angela, for you and your colleagues for performing this very comprehensive study and being here to discuss it today. Similar to Peter, I was just going to start with just a couple observations I had, as well as just pose a question to Angela and the study team. I really want to commend you, Angela, and your team for really and you kind of touched on this recently, but really the robust program that you guys put together as it relates to tele-rehab. I think, what you guys did was really aspirational in terms of, I felt like you really prioritized both participant safety as well as efficacy, having their first visit be in person, providing a number of, I would almost say aspirational equipment to patients, not even limited to also providing them with, internet access. So I thought that was really great. And I thought also should be highlighted and noteworthy that the tele-rehab program that you guys performed demonstrated a mean improvement in their functional exercise testing that was maintained at 12 months, which is, really notoriously, both for center-based notwithstanding, a really hard outcome to achieve that long after someone has completed their rehab program. So for all those reasons, I felt like you guys performed a very well-designed and rigorous program. I guess the question I have is a little open-ended. I'm assuming other places around the world are similar, but here in the United States, we're really struggling with how to get tele-rehab as a part of our usual care, and at least here at our federal reimbursement level, the conversation has really just centered around reimbursing synchronous tele-rehabilitation. So similar to what you all did, and that the participants at home would have visits virtually with the provider. But my question is more so, how do you think the results of your study would be impacted if, instead of the program being designed to be synchronous, if it were asynchronous? I think we've seen in a number of studies that an asynchronous model can be safe and effective. And I'm just wondering what impact you think that would have, not just on potentially the clinical outcomes, but more so the cost outcomes as it relates to an asynchronous program.
That is an interesting question, and the programs that we have looked at have been synchronous. In terms of the components, I sort of put an amended version of the model in the appendix for this paper, so we could actually, you could theoretically look at, if the staffing costs were less, what that would do then to, what the flow-on effects of that would be. I mean, in terms of the provision of staffing for the synchronous program, so it was twice a week, but it's not a particularly large component of the delivery cost, because most of it really was the equipment. And but yeah, that actually you could do that in that model, is take the the supervision staffing costs out of it and see what happens. Definitely.
Thank you. I'm going to bring in Michael Bellman now from the audience. If you want to unmute, sorry, I've kept you waiting a long time. Thank you for your question.
Okay, thank you. And I thoroughly enjoyed the presentation and excellent work. I'm going to come at it from a little bit of a different angle because of your limitation you raised about the exporting of this program outside of the Australian health system. And the question I had is, the program still running and in existence, and has the positive results influenced other hospitals and or provinces to adopt a similar program? And the second part would be, do the hospitals or the system and or the clinical staff benefit financially from the savings accrued, or do they accrue to the provincial administration? And does the provincial administration know that the program you so excellently performed actually saved them money?
So I'll take the first part of that first, which was about implementation. So yes, this is part of usual care in our centre. So people who come to us can choose to do home-based, they can choose to do tele-rehab, or they can choose to do centre-based. The timing of this work with regard to the pandemic, so this predated the pandemic, and then obviously in terms of uptake of tele-rehab models, that there's the trajectory of that has been altered by that. In terms of international, Narelle, can you please put the REACH and the home-based websites in the chat, please? So there has been, I can't give you numbers about uptake of tele-rehab as a program around the world. There is a website that gives people all the information they need to be able to run the program. And sorry, the second part of your question was about the financial benefits. And the problem is, I think in Australia as well as elsewhere, is that the benefits are accrued in a part of the healthcare system that is not paying for the program. So that the healthcare savings that are largely attributable to averted admissions, that's not the part of the system that's paying for these outpatient programs. Thanks, Narelle.
Wonderful. Yeah, I think Narelle is on the case already with the link, so that's great. There's a question from Grace Ann about how the virtual tele-rehab program sort of met the essential components of rehab.
Yep, so it does meet, the program does meet the essential components as defined in defining modern pulmonary rehabilitation. So we have in-person assessment at baseline, we have individually prescribed and progressed exercise training. So yeah, it does meet all of the essential components.
And then Peter, I don't know, do you want to ask your question about completion rates?
I was just surprised by the very high rates of completion in the group assigned to center-based rehab, because the premise always is like, well, this tele-rehab is going to be so much more convenient. We're going to see better completion. And so just makes me wonder how much selection bias kind of enters into it. I know it's a randomized trial, but it's the selection of who is willing to be part of a trial where they have a 50-50 chance of getting assigned to center-based rehab. And so, I would think that most potential participants would think twice about joining the trial if they didn't really think they would be able to do center-based rehab.
Yeah, and I mean, as with in this study, as with our previous study, that there was a considerable proportion of people who didn't choose to take part in the study because they knew what they wanted to do. And I think that is the case in real life as well. I think they run a pretty good show here. And I think in terms of the completion rates, I think that's a function of the service that patients receive it. And I should point out that it wasn't just in the centre here where I work, but it was at the Austin and also Western Hospital, which is also metropolitan, but in also a rural area in our state.
I guess the implication, though, is that, looking beyond the study population, but to like the target population, you might expect, you can't prove it from this, but you might expect better, clinical benefits at the population level from the tele-rehab if more people actually ended up completing sessions. But you can't really tell that from this study, but it makes me wonder, especially in a place like Australia or rural parts of the US.
Definitely. Paola, do you want to ask a question?
Yeah, thanks. Thanks for the presentation. I guess bigger implications of this, and Cátia went through this, that referral process is a problem to get people as well into pulmonary rehab. And I'm wondering if this kind of information out there will have impact or getting clinicians to understand the economic analysis. Do you think that would change at all the referral process in the future?
I would like to think so, but I would also note that I am not the first person to have demonstrated. I'm one in a long line of people who have demonstrated the cost effectiveness of pulmonary rehabilitation. So I'm not sure if we keep doing the same thing that we can expect a different answer, but I think that it does help to have some rigorous data to support a case. But ultimately, health policy is not based on necessarily the things that we think it might be best based on.
Good point. I was just going to ask, if I may, about the maintenance of the two different interventions, because I think I'm right in saying with the tele-rehab, if they didn't have their own equipment at home, you take the equipment in, and then at the end of the trial period, that's withdrawn. Is that correct?
Yeah, so in the study, everybody received exactly the same equipment.
Yeah. So just in terms of being able to maintain that long term, do you know much about the sort of maintenance of the two different programs?
Well, the qualitative work has also been published and about people's experience as participants in the tele-rehab group. I guess, as Chris pointed out, we have the unexplained maintenance effect in the tele-rehab group at 12 months of the maintained improvement in exercise capacity, which we can't explain. But no, we have got no further with that than the many people before us who have tried.
Yeah. And I think Narelle's put some resources in
some of the resources up
chat
there, yeah.
about if you want to do home-based without or with minimal
Correct.
equipment. So that's great. Thank you. Marilyn?
Yeah, so thank you so much for this presentation. So I wanted to say that, I would completely trust that these telepulmonary rehab programs in Melbourne and Australia would meet the core definition of pulmonary rehab as alluded to by Grace Ann's comment. So my question is, how do we prevent the runaway conclusions by other programs? So for example, standalone commercial entities, particularly here in the US where there's absolutely no oversight, to prevent the runaway conclusion that all telepulm rehab models are cost-effective and are efficacious.
Well, I wish I had the answer to that, Marilyn, and certainly it's becoming an emerging problem here as well. But I think that having some hard documentation as to what we consider to be pulmonary rehabilitation, and therefore without an effective exercise intervention that's individually prescribed and progressed, that people aren't going to be getting the same benefits, and it's not going to have the same cost savings associated with it. So, we don't have evidence for some of those other alternative models that do not have the exercise training component that we would consider to be essential. So, it's not pulmonary rehab if it doesn't meet the definition.
Richard, sorry, I didn't see that you had your hand up. It's blurred into the same colour as your background, I'm afraid. So go ahead. Apologies.
Sorry about that. First of all, this is a really lovely study. I'm jealous of your ability to perform such nice randomized trials in your environment. And I think that we have to accept that this result is really specific to Australia, but there's nothing wrong with that. But I wanted to drill down. We've talked a lot about the cost aspect, but not so much the effectiveness. I'm sort of wondering why you chose CRQ dyspnea as your global measure of effectiveness of a rehabilitation program. And sort of a sub-question that may have been in the paper that I missed, what fraction of the patients achieved that CRQ MID in the two groups?
So firstly, that it, in terms of the primary outcome, so that as something being of value to patients, and we know that improvement in symptoms is something that is valuable to people who are participants in our program. So dyspnea is a symptom that is important to people. So it was selected as the primary outcome in the primary analysis, which is why we chose it as the measure of effectiveness in the cost effectiveness analysis, which we did alongside the cost utility analysis. Our previous study, we used 6-minute walk distance as the measure of effectiveness. In that study, it was a co-primary outcome. Sorry, the second part of your question.
What fraction of the people achieved the MID of CRQ dyspnea?
That's a good question, and I'd have to go back to the original paper to check that.
Was it a lot, you think? I'm sorry.
Yeah, I haven't got that in front of me.
Maybe I only ask this because we've had several papers that have sort of shown equivalence of telerehabilitation to in-center, where neither group achieved what we sort of have a feeling is the ability of a well-designed program. I just think that's an important sort of outcome to stress.
I think Narelle's put the proportion of responders and was no different between telerehab and centre-based. But I think in the original trial, the mean change in the 6-minute walk test was less than the minimum important difference for both groups. So they were equivalent, but not necessarily what you'd see in standard care. And I think that, it might come back to Peter's point earlier about this is a group where they need to be ambivalent about whether they get centre-based or telerehab. And in real life, that's not what happens, is it? So, but I think, you said now, Angela, that patients get a choice, don't they? That is your usual care. So you're not doing it in a trial-based scenario now. Thank you for your question, Richard. We've got Lauren next, if you'd like to unmute.
Hi. My question is, I know there's a lot of people on here who've done a lot of work in this, and I think this sounds like an absolutely great program. We've talked about that it may be, a little bit specific to Australia. So that's what I'm asking. Does anybody know here if there's more work being done on figuring out or developing guidelines for what makes an effective tele-PR program? I know so far it seems like, and it sounds like from the authors, we're using the criteria that we commonly use for in-person PR, but there's clearly that's not the same. Like, one of the criteria is you have to have CPR equipment on site, and that's not never going to happen for virtual PR. I know there's a lot of people on here involved. Is this work being done, and where is that? And is that something we see in the near future to help us make, guide these programs?
Marilyn or Chris Garvey, could one of you come in on that?
Yeah, I can start and do the best that I can. So that's a very complicated question. I think this stems all the way back, and this is specific to the US, but in terms of the reimbursement by Medicare has really shaped how telepulm rehab is appearing here in the United States. And for those of you who may not be aware, with the end of the public health emergency for COVID-19 in 2023, Medicare ended reimbursement for telepulm rehab programs that were associated with hospitals. So hospital-based programs that were starting to emerge and to develop and to gather their own data and to publish their data. These were models that were particularly like Spoken Hub or the synchronous two-way audiovisual teleconferencing. They really had to shut down because they weren't being reimbursed, and so they weren't seeing patients clinically, and then as a result, were also not collecting data for research purposes. But through some fluke, Medicare still reimburses telepulmonary rehab through the physician fee schedule for standalone entities. So these are commercial entities. They can bill for telepulm rehab through that mechanism. The VA is another entity which doesn't have to abide by the Medicare rules, and so can still develop telepulm rehab programs. But because of all that, this emerging field of telepulm rehab in the U.S. has basically been stifled and hasn't really, where the academic centers that are hospital-based would have, written the grants to get the funding to study these questions. Though that's not happening because those programs don't exist, and the commercial entities who, understandably, are more focused on trying to increase their scalability. And their commercial value is not, that's not a priority for them. And so, the efficacy data is quite limited. And here we are stuck with no data, basically, to make these kind of society-based guidelines for telepulmonary rehab.
Yeah, I agree with Marilyn and Lauren. This is a real challenge, and it's only going to get to be worse. We don't have any national or international standards that are really clear about what is the minimum standard for clinical effectiveness, safety, et cetera, for virtual programs. There's some good starting points, but I honestly, in the US, there's only one program that I think is paying any attention to these. It's all over the map with a lot of challenges. Marilyn and Maya and Rich's survey, uncovered quite a bit of that. And as you know, it's coming to other countries. So I think if we don't get on it to some degree, or at least get it started, we're going to really be challenged in terms of effectiveness and quality. So yeah, it's a true problem that we see and hear about every day. The other thing that Marilyn mentioned is we're starting to see a decline in center-based programs. Marilyn and her team published a great manuscript looking at this in the VA. And in California, in the Bay Area, we lost 4 well-established programs, including Stanford, in about a week. So it's not something we're imagining or just worrying about. It's a reality that I think we should take a little more responsibility for.
Thank you.
Yeah, and I would add that, based referring back to my first question, that, I think a lot of people don't look at the nuances that, oh yeah, these results are just Australian specific. I think it's easy for people and entities and commercial entities, particularly to generalize the results. And whether it's maybe from our standpoint, we need to have in subtitles, a study from the United States or a study from the UK in our title to try to emphasize that could be helpful. But I feel like we need to do something where we can't just let these conclusions be made and be generalized across the globe, because they're not, they can't be.
Yeah, good point. Thank you. Got a question in the chat from Ababa about whether the two programs were effective in reducing or delaying hospital readmission.
Yeah, so it doesn't matter. It was regardless of model. Pulmonary rehab completion was what was associated with the subsequent benefits.
It's good to hear. I'm going to hand back, Cátia. You had some questions at the end of your presentation that you wanted to put to Angela, so we've got a few minutes for you to cover those. Thank you. Sorry, I've put you on the spot.
That's all right. I know what they were.
Oh, go on then, Angela. Well remembered.
So the first one was about whether COPD was more expensive. And the answer to that is I can't tell you the answer to that, because most of the people in our group, both groups, had COPD. We know that people with COPD use a lot of healthcare. We know they use a lot of expensive healthcare. Whether that's more expensive than the other smaller diagnostic groups in our study, I can't comment on, because we didn't have enough of them. In terms of the female sex being protective, I'm not sure. Certainly that the cohort in this study did have fewer admissions than the men in this study. Whether that's representative more, I don't know that there's sort of data to say that that's true across the board, but it was an observation in this cohort. So it was, I think, interesting. I'm not sure we could say it's protective per se. I think, again, the really strong message was about completion, which is that if you completed, regardless of model, that's where the benefits were to be accrued. And which model of tele-rehab should we use? Well, I think we should it's not really about which model of tele-rehab, it's which model of rehab, and it's one that someone will complete, I think, is the answer, the short answer to that.
That meets the core components as well,
Thank
which
you.
both of your models did. So yeah, that's great. Chris.
Thanks, Lindsay. I just question to add on to what you had mentioned there, Angela, and you may have listed this in the manuscript. My apologies if I don't recall, but was the completion rate between male versus female different?
No,
and if so, do you think
same.
that may have explained the difference in their hospitalizations?
Yeah, we did a post hoc. There is a table in the online supplement, which was a post hoc analysis based on sex. But no, there was no difference in completion. There was no difference in any of the other clinical things that might have explained what we observed.
Thank you.
Thank you. Angela, I'm just wondering, because I hadn't come across the term before. It was I can't even remember what it was, IRR, the rate of return. Can you just explain a bit about what that means to a lay person and how it's calculated?
Yeah, so I mean, we included that this time. The health economists that we have worked with is somewhat, I think, exhausted by the fact that we still have these conversations, because he thinks it's such a no-brainer. Like, he literally is like, are we still talking about this? And I'm like, yeah, sorry, people haven't caught on. But the idea of the rate of return was to sort of demonstrate with an intervention that does have some upfront cost associated with setting it up, that I guess was to be reassuring that, that there was an investment worth making. And so even with a very, very modest improvement in uptake, it was quite convincing that the rate of return was going to be supportive of that investment. So that was really the point of including that with an intervention that is, relatively speaking, not as it's more costly than our previous low tech model.
Okay. Thank you. Do we have any final burning questions? No, that's great. We're coming up to time anyway. So just want to take the opportunity to thank Cátia for a very comprehensive presentation, and Angela for handling all of our questions. It's like another PhD Viva all over again, so apologies. And thanks to Chris and Peter and Paola for the contributions on the panel this evening, and to you, the audience, for listening and interacting. Thank you. I also want to thank Samantha Carpen and Daniel Robledo at the ATS for all of their help in organising today. We will carry on the discussion from this journal club on ATS Doc Matter app, so hopefully you've got access to that and you can carry on the conversation there. We'll be having another journal club announced soon, so we hope to see you there. But thanks everyone, really great discussion. Thanks, bye.